Okay, we're going to go through today. There we go. We're going to go through today and just talk a little bit about the Montgomery County work that's happening there. For those of you guys who are not familiar with it, we'll talk about how we set up this project, and then we'll talk about some of our results. So I'm going to let Dawn start by giving us a little bit of background just on the work in Montgomery County Public Health.
Sure. Thank you so much. Everybody knows that this area, not only Ohio, but West Virginia and Kentucky, we were all hit really, really hard with the opioid epidemic, along with the rest of the country, in the mid 2010s. There came a time, and I was in probation at this time. And it was when I started in probation, everything was marijuana, crack, and cocaine. And that shift started at late 2000s into the early 2010s. We started seeing a shift go away, not only in Montgomery County, but across the state, from heroin to fentanyl. One of the stories that an old timer used to tell me was that he could inject in the morning with heroin, work a full day's job, come home, and be fine until later in the evening when he would then have to use again. And fentanyl changed that. Fentanyl completely changed the game, and then you add in carfentanil and the other, excuse me, the other iterations of fentanyl, really took a toll on us. So in Montgomery County, Public Health and some of the other stakeholders decided that putting together a coalition to address overdose deaths was really needed, and that's where the Community Overdose Action Team, or better known as COAT, really started in 2016. I mentioned a little bit ago that Recovery Services is an arm of our public health. And in 2016, 2017, some of the counselors over there, started talking about needing an outreach team to do post-overdose follow-up and quick response. And so a collaboration between COAT and the build of this QRT outreach team was done in early 2017. We found the funding through COAT, through BJA and COSIP, and allowed that team to grow from 2 people to now we have a team of 10. And, the focus of everything for a long time was overdoses, opiates, overdoses. And that is still definitely a focus, but we all know that the drug landscape has changed. So we have to change with the times also. So the goals of the outreach team now, but especially back then, is to reduce opioid overdose deaths and address substance use disorders of all types. Alcohol, as many of you know, that's really the most abused drug that we have in this country. So we want to make sure that we are addressing all substances and follow up for linkage to care. We want to help people with substance use disorder to find their own path of recovery and educate to increase that public knowledge and that reduce stigma. I mentioned that I was with probation before, and when you think you know everything, but you know very little, you think that you know the right way for someone else to recover. I am 24 years sober from alcohol. I did it the wrong way, the hard way. Every bump and obstacle that I could find, I put in my path. But when you're dealing with people with opioid disorder, and new things are coming out like Suboxone or Vivitrol, and you think this is it. This is how everybody is going to get clean and get into recovery. And unfortunately, I was one of those people that would try to convince those that I was supervising that this is the best way into recovery. And it's just not that way. So what has happened over the past decade is we have really recognized as a community, not only in Montgomery County, but across the state, that a person that wants to get into recovery has to be able to find their own path. And we need to be able to support them and educate, and then educate the public, because there has been such a stigma forever about it being a choice that somebody becomes an addict. And we all know that that is absolutely not true. We also want to increase engagement in treatment and other needed services. by immediate linkage, immediate appropriate linkage, which is really, really important. For a long time, people were being shoveled into treatment agencies because they were the fastest to be able to get them in, or they were the longest. And, you really wanted to stick it to them, get in there and do 90 days versus 30 days. And what we've also recognized over the past decade is there are so many nuances and so many layers to substance use and addiction that you really have to find the appropriate treatment and get them engaged when you have them, sooner rather than later, or you're going to lose them. Lastly, we really wanted to reduce the overusage and impact on other community systems, like our jail, like our criminal justice system, like our hospitals. We had all this happening with all these overdose deaths, and our jails were full. It used to be back in the day that I even thought that you used heroin as a probation officer, I could put you in jail. But this time, our jails were overcrowded. Our jail has capacity for about 650. We had almost 1,000 people in there because the heroin epidemic exploded and we didn't know anything better to do with them. Let's get them in jail. Let's dry them out. Then let's figure it out from there. Hospitals, the same thing. Hospitals were seeing overdoses over and over and over. The same person, they started to get burnt out. And then you added COVID on top of that in 2020, and our medical providers were very burnt out and very jaded. And there was a lot of stigma coming from that particular field against persons with substance use. So the services that our outreach does, our outreach is not like a normal peer team. We have 3 LSWs, actually 2 LSWs, 1 LISW, and 7 peers. And for most people, peers walk alongside somebody during their recovery and make sure that they're getting to meetings and treatment and probation or wherever. Ours is a little different. Ours is really about peer linkage to services and treatment. So we have somebody to respond to somebody in need that has been where they are, knows what they're going through, and knows the difficulty. And what our team does and what they specialize in, and probably do it as good as anybody in the country, is finding out what that treatment is needed and getting them coordinated as appropriate. We also want to do silo busting, which is interacting with all of those other organizations to really form pertinent and effective partnerships. This is something that Montgomery County and Hamilton County have done really well also. And then again, providing education, harm reduction, and really destigmatization at every opportunity. Some of the challenges, I've mentioned it a couple times, stigma. It's not only people that have stigma against persons who use drugs, but also, I spoke about it earlier, stigmas against certain paths to recovery. Everybody has their own opinion, but it doesn't mean that your opinion is my opinion. So really just supporting people to get into recovery their way, as long as it's not harmful to them. Another challenge for a long time was silos. Treatment agencies were driven by competition. Agencies were using unproven, non-data driven treatment modalities, no evidence-based. So, that was an issue. And then funding is always an issue, trying to find funding to support these teams and support sustainability. So that's what I have for you right now. And I'm going to go ahead and hand it over to Kelly.
All right. So really quickly, I want to talk about kind of the partnership role and the different partners in this. And I'm going to flip through really quickly to see if our friend from Ascend was able to make it today. I know she had some calendar conflicts. Are you here? I don't see her. Okay.
She sent me an email saying that she hasn't been able to join.
Okay. All right. So that's okay. So this project that we did is really a lot of credit to Montgomery County because they built some really innovative partnerships around data. And this building partnerships around data takes a ton of work, and that has to be acknowledged. Like, this is sort of years of negotiating data use agreements and all that good stuff. So they work with us with Core Data, and they use the Core Data platform to document their day-to-day activities. And then they also work with Ascend Innovations, which is located in Dayton. And Ascend has this phenomenal sort of back end platform that has access to a lot of other community data sets. So Ascend has access to data sets from the local hospital systems in the greater Dayton area. They have law enforcement community data sets. They have death data, coroner data sets. So they have access to a lot of other data. And the beauty of this partnership, for those of you who are a little geeky about this stuff, is that Dawn's team is at public health, and so they are a covered entity. They are subject to HIPAA. Usually I grumble about HIPAA, but in this case, it's been really wonderful. We have a platform that is HIPAA compliant. So we can, and on the court data side, we can store and maintain that data to HIPAA compliance. Ascend is also a covered entity and subject to HIPAA. So we're able to do a lot more work and data. We're actually able to share more data because we are all covered entities. And so we don't have to deal with some people not being able to see some things and some people not being able to see others. My whole career doing this work, I've really loved law enforcement data because it's not subject to HIPAA. But in this case, the way that this is set up, it's really worked for us. So what that lets us do is connect data on the back end from the QRT, the platform they use day to day, to the health systems. It becomes like a bridge. So from a practical perspective, and I think this is actually still the coolest thing, Montgomery County has access to real-time crisis notifications from the local emergency departments. Initially, we set that up with Ascend so that if somebody presented in the emergency department with an overdose, it would send a notification to the quick response team. Over time, we've kind of expanded that definition of what a crisis is. The hospitals, I think, have become more trusting. The relationship between them and public health has gotten better. And so there's a much wider variety of crisis situations that are getting referred to the QRTs. They get those referrals in real time. They can respond often to the emergency room, right? Meet with people and start providing services there, or very shortly after they leave the emergency room. And that's like a game changer, that real-time notification. The other fantastic thing is that the data from the health system automatically comes into Core Data as a referral, which quite bluntly means names, addresses, phone numbers, insurance information. All that stuff comes in automatically, and like the spelling is right and the birth date is right. It turns out healthcare is really good at getting data and storing data. And so the information that the QRT gets to do its work, to engage people, is much more thorough information, and it's much cleaner data. And when we start to try to use it for impact analysis on the back end, that makes a world of difference. Dawn, you want to add anything to that? It's really a cool partnership, and like seriously, Dawn and I all the time are cheering for Ascend, because in lots of ways I think they're really doing a lot of the heavy lifting here in acquiring them and combining these big data sets. That's a hard gig to get all those permissions and manage all that. They've been a really good partner.
I do want to add something super quick.
Yeah.
So, Ascend does work with multiple entities around Ohio. Justin, buddy, you're in Kentucky, so unfortunately right now they can't work with you, but prioritizing that type of partnership, is it going to cost some money up front? Yes. Is it worth it? Because it will get you the data and the outcomes that you can then present to other funders, to your county commissioners or your city commissioners or whoever needs to be connected. So yeah, the partnership with Ascend has been a godsend, and finding some type of data partner like that in Core Data is really important.
So for frame of reference for you all, we set up the data sharing agreements and all that part of the partnership in 2020, and probably over the summer of 2020. So we had been at it for 3 or 4 years, and we were all talking, and we were like, you know what, like we got a lot of data. Like there's a lot of data in here now, and a lot of shared data. We could probably look at this to measure the impact. So what we did, and when I say we, Ascend did a lot of this work, but we worked with Ascend to identify a panel of people from the QRT And then they matched those folks to different data sets, to the health system data sets, to the criminal justice data sets, to the police data sets, to really start to look at the system's impact of QRT. Now, those of you who like have thought about evaluation and are thinking about evaluation, there's a difference, I think, talking about it, like the impact is kind of big picture systems. The outcomes are the things that happen to the individuals, right? I'll be honest with you, in this space, I think the outcomes, that's still the hardest thing, right? But this starts to give us a sense of impact, what's changing in the big systems. And we can make some educated guesses now about what's happening with the individuals based on the impact we see and quite bluntly don't see. So we're going to go through kind of quickly the impact data that we have. And you guys, if you want to ask questions about this, just like use the hand button or jump in here, because it's more fun as a discussion, I think. So just for reference, we use data between July 2018 and March 2022. And that included 3,000 referrals to the Montgomery County team. And you can see there how those referrals break down. They were able to contact 50% of that sample, which is pretty dang good, right? So 50% they were able to contact, 50% of those people were referred, no contact. I'm sure Dawn wants to see those numbers change. But to be honest, having 1,500 people referred, no contact is a really nice control for this. So I don't hate it. I don't hate it that we have people who were referred and didn't receive services, because we were able to kind of look at them as a comparison group. When we analyzed the data, we broke it down. We looked at people who were contacted once, people who were contacted twice, and people who were contacted 3 or more times. And we did it that way for a few reasons. First of all, we feel like people who are having 3 or more contacts with the QRT, that's kind of like a different service. It's almost becoming like an ongoing care management or peer support, right? There's some ongoing support there. Whereas the 1 contact and maybe even the 2 contact groups, that's a little more like a triage and referral model. And so we wanted to look and see if we could see differences with more engagement, because if there are differences, it might help Dawn make the case to have more staff to do more ongoing engagement. So we broke the data down that way. I'm going to give you the headline first, right? All the things in your gut you think you're doing, we can see in the data. It makes a difference. And like, I don't know, for you guys, if we've been at this for a while, it's deeply satisfying to see the data and be like, oh yes, we're actually doing that. So we saw reduced overdose deaths in that group of people that engaged with the QRT when we compared them to the people that didn't. We saw reduced all system involvement. So all across the board, healthcare, criminal justice, right? All overall system involvement went down. We saw reduced overdose encounters with police. We saw reduced hospital encounters, particularly emergency department visits. Follow that in your head, because we're going to come back to that in a minute, because that becomes really powerful. We saw reduced non-drug related arrests, and this one still blows my mind. We saw reductions in new charges for violent crime. And all these things we were looking at a year pre-referral to the QRT, and then a year after their QRT engagement. So this is like looking at data, looking at these people for a full year after that QRT engagement. The violent crime, I say it every time, don't I? Dawn, the violent crime still shocks the heck out of me. I did not believe we were going to see that in the data. We only looked at it because a state legislator asked us to. And I'll be darned, we could see it in the data, though, that significant reduction. Now, Dawn comes from a criminal justice background, and my cop friends on the call are like, of course, Kelly, there's a connection here. But I didn't think we'd see it, and we did. And it was pretty powerful to look at the data. You got a commentary, Dawn?
No, when you think about violent crimes, it makes sense, because many domestic violences, many assaults, are driven by alcohol or drug use, and there's that factor in there. So I love that you captured that, because I think it's important for places to understand that this can happen in your community also if you're doing the work.
Yeah, I do. And I think it's a really compelling point to share when we're talking about issues of community safety in general. Like if you're having conversations about like why should law enforcement be involved in this, now we can point to data and see, well, it does make the community safer. That's a great reason to have law enforcement at the table. So the other interesting thing, you remember we broke that down by one connection, two connections, or three or more. We saw a slight dose effect, which means that the people who had one contact with the QRT had good outcomes, but the people who had more contacts with the QRT had better outcomes or bigger outcomes. So first of all, it's nice to know for those of you who are like still pounding the pavement, and this is, there's one or two of you and right. And you're doing the best you can. One contact makes a difference in people's lives. Facts. We know that now. But also something to aspire to. The more contact and the more support we can give to people, the stronger outcomes we see and the more change we see. Again, this is super intuitive. I see Nan Franks down in the corner and she's like, yeah, it's super intuitive, right? But it's really nice to see, and it's nice to see in the data, and it's helped us to have more compelling conversations with decision makers when we can actually show them some numbers. All right, so I want to talk a little bit, actually, I'm going to spend the rest of the time on this, talking about healthcare, specifically the healthcare data that we had, because one of the things that's very interesting that Ascend was able to do for us is not just pull the healthcare encounters, but to pull healthcare billing. So the bills that the health system sent to payers. And I want to talk a little bit about why that matters. It matters because we're talking budgets, right? Like at the end of the day, we're talking budgets and we're talking money. And particularly right now, we are very much in a cost-cutting environment. All of us are in a cost-cutting environment. So being able to show people and make the case that an investment here, it's not just a nice program, right? If you make an investment here, this will actually help you save money in other places. It's a really important thing to bring to the conversation. And it's been very compelling in talking to policymakers at the state and the county level. We focused a lot on healthcare cost savings here, and that's for two reasons. One, healthcare data are way better and easier to get than criminal justice. Criminal justice data are messy. Criminal justice cost is messy. But also, generally speaking, if we keep someone out of jail or prison, we're still going to pay for jails and prisons. We're not in a place where we are going to keep a lot of people from getting arrested and now we close down the county jails, right? Like that's not a realistic kind of cost saving measure. However, if people show up in the emergency department less, that costs less money because healthcare is a fee for service model. So there's real and tangible cost savings to keeping people out of hospitals and keeping people out of health systems. The other interesting thing is that most QRT clients are insured through public funds. So in the sample out of Montgomery County, 60% were Medicaid, 15% were Medicare. Dan asked me earlier, we are replicating some of this in other counties. And looking at the Hamilton County data, they are pretty dang similar, 65% Medicaid. They have a specific program that's more of like a hotspotter program that's 80% Medicaid. So Medicaid costs are paid by the state. And Medicaid budgets, there's a lot of debate about that and how we cut those budgets in the political environment. So it's really nice to be able to talk about the cost savings of this and how that fits in that larger Medicaid conversation. So I'm going to show you two examples of this and how they add up. So these are the cost savings for emergency department billing, and these are averages. So in Montgomery County, if a person had one contact with the QRT, in their year after that contact, there was a $9,000 reduction in their emergency room billing. If they had two contacts with the QRT, that jumped up to $21,006. And if they had three contacts with the QRT, that was $22,000. And that's the year after compared to the year before. So we played this little game, right? We did back of the envelope math. So we had 1,000 people in the one contact group. So that translates to 9 million in reduced billing. We had 300 people in that two contact group. That's 6.5 million. And we had 250 people in that three contact group. That works out to be 5.5 million. So in total, the QRT reduced emergency room billing by, on average, $21 million over the course of the sample. Now, Dawn, what's your program budget? Is it $21 million?
No, nowhere close to that. And my program budget is made up of grants. So, that's
so there really, you go.
Yeah.
August, I see you have a question.
August, if you're talking, you're on mute still.
It looks like he's trying to unmute, but maybe.
Oh, okay. Oh, nice.
Okay. Let me add something in as
type it in the chat.
Yeah, as August is either getting off on mic or putting it in the chat. So will you go back one slide really quick?
Yes, I can go back one slide. Oh, I got to go back through my little math. There you go.
Okay, so Kelly just talked about criminal justice savings. They're kind of hard to realize because we're still paying for jails and prisons, right? But a lot of that, a lot of those services are based on how many people are in their jails or prisons at any given time. So there are still plenty of criminal justice cost savings that can be realized, right? So we all know that jails have become like many communities' de facto largest behavioral health entity. You don't know where to take them. You can't take them to the hospital, take them to jail if there's any kind of criminal element to it. So yes, we're still paying for jails, but jails also have to pay for medical and mental health care in there, and most of them. They have to pay for food. They have to pay for, the clothing for the inmates and all that. So there's definitely still cost savings that can happen if we can keep people out of jail and prison.
Yeah, there definitely are. And I think there's a future iteration of this where we try to look more in detail at those criminal justice cost savings. It's just a lot more complicated than I think I ever realized starting it. August, did you get it now? Can you unmute? Thanks, Dawn. Now we'll start interpretive dance if that doesn't work.
Yes.
How did you track the ER visits with the QRT participants reviewing medical records? Yes, Michelle. Well, not necessarily reviewing medical records, but Ascend has those data of all hospital encounters for the Dayton hospitals. So they went through and matched person to person and looked for each QRT participant. They were able to look and see how many times that person was in the emergency room and how many times that person was in the hospital for other things. And the billing for that. Now, I feel like I have to make the honest caveat that I don't know how many of you have ever looked at bills from a healthcare system. Those numbers are kind of made up. Like the bills that the hospital sends are not the amount that they're paid. And we don't have access to the actual Medicaid payments, which would be really nice, but we might get there one day. So we also looked at overall hospital billing. So looking at the emergency department is pretty important because there are some very important goals and incentives attached to reducing unnecessary emergency room visits for health systems. So that's a piece of data that's nice to have, but we did want to look at overall hospital billing. And you can see, we see same trend, but in this case, we looked at that group that was referred and had no contact, right? So you can see that just, I guess, being referred to the QRT had some kind of effect on and changed people's behavior because they had a reduction of $2,000 in hospital billing for the year after that referral than the year before. But you can see how much less that is than for those clients who actually had contact with the QRT. So when we work out the back of the envelope math on this, and I'll go slow, you can kind of look at those. Here's like the summary of that. So doing nothing, right? Just making a referral to the QRT, that reduced the hospital billing by $3 million. But the QRT engagement reduced it by $36.8 million across that whole group of people. So again, Dawn's budget is not $36.8 million. So let's say we gave Dawn, I don't know, what do you want? Dawn, a $5 million budget?
That'd be fantastic.
She's still saving money, right? Like she's still saving money. And that becomes a very compelling conversation. So this goes back to Dawn to talk about using the data. I think she's going to try to make a compelling case to you guys.
August was able to get his message in. So let me do that and then I'll jump into that. So he said, you are seeing diminished ROI, return on investment on the amount of savings as the amount of the individual's contacts with QRT increase, particularly when it only jumps from 21,000 to 22,000. Do you see the same result in the effectiveness of the QRT once said individual passes or that you are dealing with past 3 contacts?
Yeah, we did not look past 3 contacts because for this team especially, they just don't have the resources to do that ongoing support. We do have a sample in Hamilton County that's much smaller. That program is designed for ongoing support. And once we get that sample a little bit larger, I think this is something we'll look at is like, what is the effects of that ongoing engagement?
Great. All right. Thanks for the question, August. So Nicholas, I'll get back to your question, or we'll get back to your question in just a second. Just let me run through this super quick. So funding, that color of money, that's what everybody needs. So, we started with grant funding. We're currently maintained by the same. However, by having this data, and this is what I told my health commissioner the other week. I said, I am doing these presentations and going to these conferences to talk about this, not because I get to travel, right? Or I get to sit in front of a computer and talk to y'all. It's because you want that name recognition that you're doing good work. Hamilton County has had it forever. I mean, Hamilton County kind of led the charge. Them and Lucas County led the charge with this. But, understanding that the more people know about what you're doing, the more you're going to get award money. You're going to get grant money. We're also working really hard to make staffing sustainable through creation of budget lines, whether it's through public health, through our Montgomery County and the commissioners, or state budgets. And we're doing that by showing successful outcomes of the team's work. Kelly and I and Hamilton County and several others went down to DC in July and shared this information to try to get, lawmakers and their staff to kind of think about, why this is important and continued funding is important. I went down with Aaron Reed, the director of Ohio, along with Tom Fallon in September to kind of talk to other states about this. So once you have this type of information, you want to get it out because it will lead to more sustainable funding than not so much reliance on grants. Look, this has taken years to get to the point where we can actually start advocating for a budget line inclusion. The good thing is we have this information and Hamilton County has this information. So even though you don't right now, you can take our data and our information and take it to your higher ups and say, look, we're not doing this right now, but look, Dayton's the same size as we are, close, or Hamilton County and Cincinnati is close, and look at what they've been able to do. So we are willing to share our data with whoever, wants to use it in that way. Now we have, those measurable outcomes, that show the efficacy and the success through the data collection and the analyzation of it. This is why data partners are absolutely paramount to the success of a QRT team. You have anything to add, Kelly?
No, you're much more compelling than me on this.
I do want to add one more thing. So I talked a little bit about, our partnerships with the Send and Core Data. They do include, money. They love this stuff, but they're not doing it for free. They're a business at the bottom line. You don't have to, at the beginning, you may not necessarily need to find a pot of money to partner with, Ascend or Cordata or whoever you have in your area or state. I suggest starting small. Reach out to local universities and colleges that have, data analysis and data analytics and a public health track or a school of medicine, and see if they would be willing to work with this as a project with you to start getting some of that. You're not paying them because there's their students and these are professors that are maybe doing this as a part of their graduate work or thesis or whatever. So you can start smaller and work up to some of those bigger partnerships, because again, you start small, you show these data analyses, and then people are all of a sudden, oh, okay, well, this is why you need this money. We'll give you the money.
I think that's it for us. That's all we've got prepared. Let's see.
That was
But I see
fantastic.
more questions.